something about patient-reported outcomes and the whole multidisciplinary, multi-professional team. Um, it's a virtual happy hour for me. It's a lovely evening, and I'm sure we've got better things to be doing. Thank you very much for all coming and joining in this. The attendees, thank you, Julie and Richard, for inviting me and looking at the chat room and so on. All the collaborative partners. Edgehill University funds 1 day a week in terms of the research time for me. The Head and Neck Patient and Carer Forum and Research Forum have been invaluable. That's what HANC stands for. And then Derek Lowe is the medical statistician who is retiring this year. So I wouldn't go past this point without recognising his massive contribution to all that has taken place over the years in this topic. 60 minutes, it might be less. It really depends on what you want to do as a group as well. I was going to spend about half the time looking at the PCI, some thoughts around that, a quarter on the e-holistic needs assessment issue and PCI, and a quarter on the QOL metric. And I'll explain more about those as we go along. I will try and keep an eye on the time. I was just wondering if there was 3 natural breaks in that, and Richard's going to keep an eye on the chat room. Obviously, if there isn't much to discuss in this difficult sort of virtual forum, so be it. But if there is, I've sort of in my own mind built in a bit of time for some sort of chat within a 60-minute framework. You can always finish earlier, of course, and that's not a problem. In terms of where we start, of course, all of us on the group realise the impact of cancer, the impact of head and neck cancer, the difficulties in terms of physical and functional, emotional, and the social consequences of cancer. And I would just flag up this web resource, which I've sort of populated since 1992. And I'm quite proud of this, Handle on QOL. I'd like to believe it contains near enough every single study that has ever been published in head and neck cancer, quality of life, and has used a questionnaire. And so you can search on a particular topic such as dysphagia or intimacy or whatever it might be, and you can see what studies have been published in that area. And of course, not only is there a huge amount of questionnaires on that website, it just shows how complicated and how intricate and how detailed the work that we do in terms of health-related quality of life is and how important it is. Questionnaires are always going to be a very subjective, pale reflection of what's going on. They're not absolute, they're not static. And I think that when I speak to patients and carers themselves, they would throw up their hands in alarm and displeasure at the fact that quality of life can be reduced to just a couple of questionnaires. And of course, that's true, and we accept that. And it sort of led me on to wanting to develop some sort of prompt list to try to help patients express themselves better when attending clinic. And so there was a review process looking at questionnaire prompt lists. And of those of you who know about questionnaire prompt lists, they've been used since the 90s, been shown to be beneficial, used in oncology and so on. And they are questionnaires. Questions. So what is the best case scenario? How likely will my treatment be to control my cancer and so on? And they're questions that patients might wish to ask of us to get a better understanding of what's going on. And of course, that in itself is a little bit complicated. And I was sort of thinking really in terms of the quality of life questionnaires, in view of the questionnaire prompt list, can we make it even more simple than this? And that's where the prompt list came up. And this is the PCI now at 56 items, 4 domains, and patients can choose to tick as many items as they wish to talk about in relation to that clinical consultation. And of course, there's a whole range and variation of different items that's possible to raise. And in addition to this, because it's a multidisciplinary, multi-professional group with cross skills, if you want, there's the opportunity to actually allow patients to identify who they might wish to speak to specifically about a particular issue when they attend the clinic. And we've shown it's feasible and appropriate. It's the basis for a conversation. We've published on the hard to reach group, and by that I mean the older patients, those where there's social deprivation and educational poverty. It gives multiple opportunities for intervention, for multidisciplinary referrals and signposting, and agenda for change in practice and so on. Back in 2010, it won some national best use of IT in patient and citizen involvement in healthcare. So there's a certain pedigree to where it's coming from. And that was supported by this paper from colleagues in New South Wales in Australia, totally unsolicited. They looked at unmet needs measures, 14 of them, and their conclusion: we recommend the PCI to be used to measure unmet needs in head and neck cancer setting, considering the importance of content validity over quantitative psychometric properties. As a prompt list, 56 items, it's not amenable to your standard psychometric Likert type analysis. And the face validity and content validity and the way that it's been made in partnership with patients and carers is really important, of course. How it's used, you can go from the simple to the complex, the whiteboard down to the iCloud, and of course it aids communication. It can be used in audit, hospital records and networking. I like the idea of the whiteboard. The whiteboard was a colleague where they just put the items on a whiteboard and the patient just tick what they want to talk about. They come into the consultation, the whiteboard is wiped away and given to another patient. Paper I use in the peripheral clinics to allow patients to do that, and then that can be scanned and then put in the hospital records if that's the system you're using. Most of the work, obviously, at Aintree has been with an iPad, so a device in clinic in the firewall of the hospital where patients attend and fill it in. We are looking at developing the patient portal across the network and also cloud-based resources and all of the difficulties of having that sort of data on the iCloud. It can be used face-to-face, and in terms of the COVID-19 pandemic, I'm sure, although it's untested, that the prompt list would enable a more informed conversation with a patient over the telephone if it was sent. And what I've been doing during the COVID-19 pandemic is sending the prompt sheet to the patients before that telephone consultation, just to make sure that they've got the opportunity to bring forward things that they might otherwise miss. The PCI in itself is a follow-up questionnaire or follow-up prompt list. The questions or items at diagnosis are subtly different, and I think there is that distinction. Issues like the cause of the cancer, lifestyle, HPV, and so on, treatment related questions, what will I be like, what sort of follow-up, social care and dependency and finance and so on. There's all sorts of issues that tend to be more of a focus before treatment, raising the issue of clinical trials and contributing to research, and also the patient and carer support group itself, how to access that, and allowing that sort of discussion to take place. If patients don't tick something, it doesn't matter, you don't need to talk about it. If they do tick the issue, of course, they can have an in-depth discussion with anyone who's appropriate regarding the issues they want more information about. In terms of the frequency, we started in January 2008, and apart from a hiatus in the middle of 2012, it's been continuously used in clinic. On that left-hand side is Ruth, the volunteer, with her husband, John, and they've been really helpful to allow patients who otherwise would be more reluctant to use a computer system to be able to complete the PCI. And we've published on how to be able to use it as an integrated part of clinical care. So data is always challenging to work through, and we don't do it that often, to be fair. It's time consuming to be accurate. But if you looked at data from June 2008 to January 2017, 1,506 patients, PCIs rather, from 511 patients coming through the clinic, 109 of which had ORN in 445 clinics. And then if you want to look at late effects, which is an interesting area, 105 at 5 years, 99 at 10 years. And then the late effect profile, even at 10 years, You can get a flavour of what patients still want to talk about, whether it be the follow-up for their first cancer, whether it's a follow-up because they've had recurrence or a second primary, or whether it's a follow-up because they've got osteoarthritis necrosis. You can see dental health, dry mouth, fatigue, fear of the cancer coming back, salivation, swallowing. And you can also see that if you look at the ORN group, 47% were wanting to talk about dry mouth still, 39 still dental health, 31 mouth opening. There's still a lot of issues even in that late effect stage where that progressive dysfunction is happening, that patients need some guidance and advice regarding. In terms of numbers of patients, is relatively modest. This group from Germany, using the OncoFunction, published from 2013 to 2017, 846 patients completing the PROM, a total of 3,610 visits. And then this group, I think, must get a huge accolade. This is the Memorial Sloan Kettering, who have been using ePro. So I'm just trying to encourage you to go down this route. From August 2018 to February 2020, you've got 4,154 head and neck cancer patients completing the ePro. And so obviously by the time you get to healthy informatics platforms, you can build this into clinical practice. And I'm sure that's something that we would want to be ascribing to if at all possible. In terms of what's happened over time with the PCI, just a few brief comments. Obviously the international collaborations, and I recognize those with huge gratitude and warmth. The various translations that are available on the website. Going back some time, it started with Maria and Walter from Florida. They used it in an oral maxillofacial type clinic, and they found salivation, fatigue and tiredness, chewing, eating and swallowing as being right up there amongst the top issues. And then Ivy Jungerman with Louis in Brazil, Sao Paulo, 2017. She's a speech and language therapist, and that's where her interest became involved. And you can see from the people that the patients wanted to talk to, the speech and language therapist was very high because that was the clinic they were attending. But if you look at the bottom, even in that clinic, seeing the speech and language therapist, and did I use the wrong word saying even? And that's not meaning it in a derogatory way, but in the context of seeing a speech and language therapist as part of their follow-up, fear of the cancer coming back is really high. And we all have a role in trying to address that issue. It's really prominent. And it's a very difficult issue to say to somebody, well, are you worried about the fear of the cancer coming back? Because they will say, why are you asking me that question? I had put it to one side and reconciled myself, and it's an unsolicited question. But if you give the patient the opportunity to raise the issue at all, we've shown in our research how positive it is to allow them to have that opportunity. So fear of the cancer coming back within that context of this study, dry mouth, chewing and eating, speech and being understood, and swallowing. And then we had this international collaboration, 2,136 patients from 19 units across the world. And thank you so much to all the collaborators. And what was astounding to me about this is, again, you've got fear of the cancer coming back, dry mouth, chewing and eating, swallowing, speech, dental health, fatigue and tiredness, and so on. But if you look on the figure 2, there's a huge cross-cultural variation, which is really interesting and needs more research as to why certain groups of patients in different healthcare settings will complete less or more items in terms of physical function and treatment-related social care and psychological. And there's a huge variation across the world potentially, and some cultures are less inclined to give the opportunity for patients to express their concerns and work it through within their healthcare systems. We then have the group from Malaysia. They first published on the PCI in 2014, but more recently they've published in 2020. And their conclusion, routine follow-up consultations should incorporate the PCI and NET prompt list to enhance patient-centered care approach as the type or number of patients' concerns are shown to reflect their health-related quality of life and psychological distress. And then this last group that I've just highlighted, there are others, and I apologise if I've missed you out. I can't mention everything in the time, but this group from France, this is 2021, so it's right hot off the press. And their profile, again, fear of the cancer coming back, dental health, dry mouth, fatigue, speech, voice and being understood, and so on. And their conclusion, identification of patients' needs and concerns, along with the multidisciplinary management, and so on, is so important, essential steps towards improving quality of life in head and neck cancer patients. Oh, and then the last one, sorry, is this one from Annelies in Copenhagen. Annelies is a clinical nurse specialist. She's taken on the challenge of a randomized trial, and her randomized trial is using the PCI or not at the point of discharge following a head and neck surgery, 2 weeks later, and then at 2 months. And again, you can see the fear of the cancer coming back right at the top there, chewing, cancer treatment, dental health, wound healing, right at the very, very top of what patients are wanting to get that multidisciplinary advice for. And the huge range of items that the patients might want to talk about. And it's not an item reduction. So if an item's not ticked, that's fine. It doesn't need to be talked about, but it's there just in case at any point in time. And in terms of the collaborations, just a brief comment on the other PCIs that are in various stages of development. There are others that are not listed that have fallen by the wayside. And I'm very grateful for those colleagues in other chronic diseases and cancers who have sort of taken forwards this initiative of trying to get prompt lists into routine clinical practice. So now on to the randomized trial, very briefly. This has been published in 2020. It was recruited, unfortunately. It was balanced, but we were aiming for 358 patients, and we ended up with 288. That was really an error. Really, we needed a third site to help us get the right number of patients. And then the baseline clinic, for those with the PCI arm, it was 140, and for the non-PCI arm, 148. And then from that, of course, there's dropout in that year of follow-up with recurrences and so on. So at the end, we had to close early because it's an intervention that was face-to-face. We didn't feel that it could really be done over the telephone during COVID. And also, actually, the COVID pandemic might change the findings anyway. So we ended up at the 1 year point with 100 in the PCI and 105 in the control group. So we were aiming for 312, we got to 105, a little bit disappointing, and that's where it is. In terms of the items and the number of items being selected, baseline 5, 6 months 3, and then much fewer at 12 months. And then in terms of the type of items, dry mouth, feeling very strongly in this group. Dental health again, chewing, salivation, fear of the cancer coming back, pain in the head and neck, fatigue and tiredness. Interestingly, only 2 items were not selected. It probably means it's the context of the consultation more than anything else, but regret about treatment and sexuality. Intimacy is on the list. I don't know what sexuality means in some ways myself. And obviously that goes down to the patient group themselves to work out the wordings and what they actually mean. Regret about treatment is unusually ticked. And if it is ticked, it really needs to be dealt with in terms of balancing up the side effects of treatment and the intention of treatment and the context of how the treatment was given. In terms of the length of consultation, at baseline, the median was 11 minutes in the PCI group versus only 10 minutes in the non-PCI. There was some concern that with a long prompt list, it might torpedo the clinic. At 12 months, actually, the PCI group was slightly quicker, 8-minute consultations compared to 9 minutes. There is huge variation in the time of consultations. There was one consultant that had about an average of 6-minute consultations, believe it or not, in follow-up, something like that. And there was another consultant that had consultations that went on for about 15 to 20 minutes. And there's no perfect length of time in a consultation, but time is very important when we're seeing patients, and to use that time efficiently and effectively. The number of PCI items ticked influenced how long the consultations were. We don't necessarily need longer consultations. GPs have been asking for that. My belief is we need more focused consultations. We need to really make the use of the teachable moment. And we must remember that clinic time is costly, and we need to optimize the efficiency and the effectiveness of our clinical time with patients and their families. In terms of the primary outcomes of the trial, and the primary outcome basically was a bit hopeful, in the sense that by using the prompt list at each consultation, it would somehow improve quality of life. And the measure was the University of Washington scale, and we reported the percentage scoring fair, poor, and very poor. So at baseline for the PCI, it was 30% reporting a poor quality of life, and then it reduced to 22% at 1 year. And in the control arm, it was 27 with a poor quality of life, reducing to 25%. But then when you factor, sorry, going the wrong way, when you factor in the adjustments for consultant, clustering, tumor site, and treatment, the absolute difference was 4.8% in favor of the PCI group. And so although there was a strong tendency towards a benefit, it didn't reach statistical significance in the overall quality of life question, which is a fairly crude question of quality of life, of course. In terms of where I was most interested, because I think the PCI is helping in the discussions around the emotional aspects of having head and neck cancer, and how the clinicians deal with that and help the patients address that and get support. Particularly, for example, fear of recurrence and anxiety and so on. There was a difference in the socio-emotional construct, 4.6 units with full adjustment. And so there was a difference, as you can see in the box and whisker plots, in favour of the PCI at 12 months, particularly in the socio-emotional domain of health-related quality of life. And then what was fascinating in a way is that if you look at all of the domains within the University of Washington, there was a positive benefit from using the PCI. And admittedly, wherever that threshold is for a clinically meaningful, significant difference, whether it be 8 to 10 points, you can see that for pain and anxiety and chewing and swallowing and taste, there was getting towards being a significant difference and clinically meaningful, accepting that the study was underpowered. In terms of the qualitative work, I'm very grateful to Sherith Semple and her colleagues who have looked at the interviews that were performed on those consultants in the PCI trial. And I don't want to summarize too briefly this important aspect of it, but basically the consultant said it involved minimal training, enhanced the consultations, was easy to use, allowed a flexible approach to consultation. There was no issues on the PCI that they felt they were inappropriate. It was helpful. It empowered patients to discuss sensitive topics, such as fear of recurrence and intimacy, and it streamlined the consultation more effectively and more efficiently. The bit in red is what I've added. I think that when we train as clinicians, whether it be nursing, allied health professionals, doctors, we can sometimes be too driven by knowledge. And that knowledge is very important, of course, but actually we perhaps don't actually recognize the value of giving the patient the opportunity to raise things that they want to talk about and to use that effectively. And I would challenge that there's actually a role in actually altering the medical consultation and education regarding how consultations are given using the evidence from the prompt list approach. In terms of health economics, this was very elaborately done and beyond my skill set by Bangor University, by Rianne and colleagues, Klinos and Tien, and just a few brief summary slides here. The intervention was incredibly brief, and the consultants did not feel that they needed, it was a secondary training session. It was built in that after 4 months, they would have a secondary training session, but they felt they didn't need it. And actually the intervention cost to deliver it was calculated as £13.71. And so if you think of interventions, that's an incredibly low cost considering a day out or 2 days or 3 days. So it was a very simple thing to explain to consultants, and consultants were felt enabled to be able to use this approach in their practice. In terms of benefits, there was a cost benefit to using the PCI compared to non-PCI. I think these figures mean that it's about £300 cheaper in healthcare per patient per year to use the PCI. So it's not more expensive. If anything, it cheapens this incremental cost effectiveness analysis ratio, and that's then demonstrated on this slide. So this group are published on this, of course, and it's been shown therefore to be cost effective and quite a low cost intervention. And I'd just like to conclude on the PCI part by acknowledging the NIHR funding for this RFPB grant, and also, of course, all the colleagues involved in this work. So, Richard, that was a very quick fly through the PCI. Is there anything in the chat room that you want me to address?
So there isn't, but while we get a couple of questions together, I've got a question. I've unmuted myself and everything. So
I won't share the screen. I'll leave my screen up, shall I? Yeah. Yeah,
that's fine. Yeah, that's good. So fear of recurrence comes up time and time again. And I noticed that similar methodology has been used in other cancer specialties, other tumor sites that actually have many more patients than head and neck. So is there a difference between head and neck and other forms of cancer? And, you know, what is the way we should address patients' fear of recurrence?
Yeah,
it's a common thing in oncology, or, you know, is it a unique thing in head and neck?
Well, I don't know if Jerry Humphries is on the group, but obviously Jerry Humphries has published a lot on this as the clinical psychologist as part of the team from way back when. And it'd be wrong for me to even try to go there in some ways, Richard. All I would say is that for head and neck cancer, I think that we all sort of say to patients, actually, you know, you're going to have this treatment, and if it's not going to work, unfortunately, it tends to come back within a year to 18 months or so, and the outlook can be very difficult indeed. And that might be a different sort of conversation than breast cancer or prostate cancer. And I think that when the outcome potentially of failing in head and neck cancer is death, I'm sure that it really does concentrate the mind for the patient and their family. And that concentration of mind is something that can be triggered very easily by the symptom, a little bit of a sore mouth. Oh dear, it's coming back. Or I've got a bit of pain somewhere. Oh, it's coming back. And the symptoms that we get from the mouth are so common, and head and neck. And it may be different, a breast lump, you know, and so on. So patients are getting bombarded by possible symptoms of recurrence. And so therefore, I would argue that there is an intensity within head and neck cancer that is perhaps more than other cancers. And when we published on our longitudinal sort of thoughts around dealing with fear of recurrence, what I think Jerry was sort of saying is that repeated reassurance that patients like to mention, even at 6 months or 12 months or 2 years, oh, this symptom, of course, it's normal to have a dry mouth. It doesn't mean that you've got recurrence or whatever it might be. And to have that opportunity. And also we found that it's very difficult or impossible in a way, apart from personality assessments, to predict which patients are more likely to have fear of recurrence at any particular time. Hence the importance of giving that opportunity for them to mention it, because you can't necessarily predict which ones are going to want to talk about it at any particular time or for whatever reason.
So there are a few other questions come in. One of them leads from that, and a question's come in. If contact with doctors increases fear of recurrence in patients, should we be reducing the number of contacts with doctors and maybe focusing around maybe therapist, AHPs, or symptomatic support? You can have a think about that one. The next questions for patients, PCI is an excellent in collecting information, but how is this information disseminated and coordinated is critical. Patients will benefit from somebody to coordinate their individual needs response. So I guess they're looking for a more personalized, maybe professionalized way of dealing with the data. And then another question's come in I might have missed it, but did you present data measuring PCI in the consultation when comparing PCI versus non-PCI interaction? Did you present that data?
Okay, I must have gone fairly quickly. In terms of the contact, I think, again, when we speak to patients, I think coming to clinic face to face and having that physical assessment is really reassuring to them. And I think some patients will get quite anxious about coming to clinic because of what's going to be found possibly and what might be said. And yes, there must be a trade-off between having the reassurance of being checked in some way versus just having somebody else have a chat about it or being on a remote follow-up totally. We don't have a blood test that can test for recurrence and so on. And so it's a real double-edged sword, that one. And in many ways, I think where we'd be moving forward in terms of stratification is giving the patient more choice for them to choose in a way their frequency and what they want to talk about. I think would be a very grown-up way of doing it. And some patients have immense fear of recurrence and actually want to be seen every 2 months, where other patients would say, actually, I'll see you every year or not, or whatever. I think there's a huge variation in terms of what patients want. But yes, I accept that in a way, there's a huge reassurance after coming to clinic and being told you've got the all clear, and yet it does in itself raise anxieties and issues regarding that. So I don't know the full answer to that question. The dissemination, I think, is really important. Obviously, the PCI is there at the moment for the patient and also that interaction. Ideally, with a network, the patients who tick, say, more than 5 items, we know they've got a very poor or relatively poor QOL for whatever reason. And you can have patients who've got more than 5 items triggered to be alerted to the speech and language therapist or the clinical nurse specialist and so on, targeted referrals. And of course, the wider dissemination of the PCI comes from papers and from the head and neck groups themselves, and patients and their carers are huge advocates in this sort of area of clinical care. In terms of the PCI versus the non-PCI, I did sketch over that just because of brevity. There's a huge amount of detail in the papers on this that are coming through, not only about length of follow-up, length of consultation rather, but clinical benefit. And those papers are generally open access. So the detail is there in publication, Richard.
And one last question, I think. What are your thoughts on the Macmillan Head and Neck HNA tool?
Right, well, that's a good segue. Someone's brought us into that because that's the next little slot. So if we use that as whatever that segue expression means, I will move on to it. There we go. Beautiful sharing that is, Richard. Fantastic. A couple of comments really about this, and it's more just in a sense for encouragement as well as information. The e-holistic needs assessment in our country is that opportunity for patients to help identify and address their unmet needs in that personalised care and support cancer agenda. And it's slightly different to the PCI in the sense that patients are able to score what they're putting in and therefore sort of get some sort of rank. Again, that adds a degree of complexity, and I was very keen not to have another Likert quality of life, head and neck cancer, PROMS, Likert questionnaire. But it actually adds a little bit, obviously, to be able to get a rank of significance for each individual item. It then might take 10 minutes to complete. Then there's a conversation around it that it usually says on here 20 minutes. And then from that conversation, a personalized care plan is developed and so on. And in principle, the e-holistic needs assessment is something from baseline, from diagnosis, through critical times, patients, and in a regular interval really for patients to be able to use to develop this personalized care plan and support plan. And the way that Macmillan generated this was a lot of items. I call them prompt lists. I don't want a checklist. I don't want everything to be ticked. I want the patients to prompt us as to what they want to talk about. And in this, when selecting, please score each concern between 1 to 10. And that's not the idea of the PCI. Some things are, if somebody ticks nothing on the PCI, that's brilliant, because I feel they've got there, and we could talk about the dog and the weather and the holidays. And yes, we could talk about clinical things as well, but my worry about missing something or giving them opportunity to talk about something is negated. So it's not a checklist, the PCI. But patients will fill this in terms of emotional concerns and support and spiritual concerns. And what happened was that with Macmillan, there was a reflection on the fact that some of the items really weren't specific enough to head and neck cancer, because it's for all cancers. And so we did a mapping exercise, and these 12 items were felt to be missing from the holistic needs assessment. Dental health, which we've seen is important, mouth opening, pain in the head and neck, salivation, shoulder smell, regret about treatment, self-esteem, and so on. They were missing. So there was a mapping exercise. What is on the holistic needs assessment versus what is on the PCI? And then we get down to this translational issue, because is sadness and depression the same as mood, and so on? And when colleagues have translated it, can be quite difficult to translate certain questions or certain prompts into different languages to get that same level of meaning. So there was a mapping exercise and so on. And basically, we've got data from Andrew Brittle at the moment, and we're looking to publish this with Macmillan at some point. COVID obviously has taken over a lot of priorities, but Andrews gave a brief summary a little while ago. 56 different organisations using the holistic needs assessment head and neck PCI extension. 14% of the assessments were the general holistic needs assessment, but then in the passage of time, 2019, 2020, it's gone up to 2/3 of assessments being done by the extended module. 6,403 assessments, 25,000 concerns have been identified. And then the two boxes here just wants to make something. The top box is about all of the cancers. So you've got 121272 assessments, but the average concern for all cancers in that time point for patients filling in the assessment was 5. If you look at the PCI head and neck, you'll see the number is small, 3,412 relatively, but can you see the number of concerns at the bottom there on the right hand side? 7.4. And yes, I think that potentially head and neck cancer patients need to have that voice to express their concerns. And it might be that given the position of the head and neck cancer in terms of social function and emotional function and the consequences of all of that, yes, there's a lot of concerns. And there may be more concerns in the head and neck cancer group than there are in other cancer groups. If you look at the actual items that they were ticking, there's 2 slides here, and then I'm finishing on the holistic needs assessment, and we can have another little break. But at the top there, eating, appetite and taste, swallowing, tiredness, sore or dry mouth, worry, fears, anxiety, pain. And then the yellow lines are where the PCI items that are being added in come in. So pain in the head and neck, you've then got dental health, mucus, salivation, and so on. So at the top there, you've got eating, appetite and taste, 1,341. These are done at baseline, pre-treatment, so that muddies the water slightly, because I think there are issues, as I said before, at a pre-treatment that are different to follow-up. And then how often it's used in follow-up and so on is difficult to really be clear on. Gastrostomy tube feeds in there. And then the lesser frequency comes down to these ones: travel, self-esteem, independence, smell. Regret about treatment, 129. That raises issues for me in a way, a regurgitation, and then down at the bottom, feeling at odds with culture, belief, and values. And before I finish on this, but I'm just going to go back. So that's the order there. If you look at the average score, I was thinking, well, how would look at the average score? Certainly anything above 6 is going to possibly be a bit more of a trouble. So they're actually ranking these now, and you can see that a lot of them are in their 5s, but they're at 6.19. Worry, fear, anxiety, right up there. Dental health, 6.17. What other sixes are down there? I come down there, children are in there, as well as the partner. And let us not forget the partners and the importance of partners and carers in getting through this devastation. And then looking down here on that right-hand side, unable to express feelings. You know, we need to enable patients to be able to do that. Hopelessness, oh goodness me. And then somewhere down here, I really felt sad because there was guilt. Where's guilt? Somewhere down here, guilt at 6. You know, patients reporting feeling guilty about cancer is something that we need to be addressing and tuned into. And so in a sense, there's a synergy here between what the e-holistic needs assessment provides and the additional sort of head and neck specific. And if I had a sort of magic wand, which I haven't got, of course, I would be suggesting that there is benefit of having cancer specific modules on top of a core cancer e-holistic needs assessment to really be able to tease these things out and to allow the clinical teams to focus on things that are very specific to a particular cancer group that might not be relevant to another cancer group, and to give it, in a sense, a little bit more utility in the way it's used. Potentially this data could go the other way and actually be used to refine again what is on the PCI list, although you might find that actually a common tool could develop using all the information that we've gathered over the years in various ways. So that's the little bit about e-holistic needs assessment, Richard. And I'm very grateful to Macmillan, of course, for allowing me to talk about it, and also their encouragement and enthusiasm in relation to the project itself. Is there any questions regarding the e-holistic needs assessment issue and head and neck cancer?
So Simon, you've got the attention of 95 people. There are questions coming in.
Yep.
I don't think they're completely linked to the holistic needs assessment, and I suggest I store these questions for the end. Okay. And in the interest of time, we crack on. Okay. So it's 1:45. I'm happy with that, Richard. Thank you really much. I'm going to now just briefly talk about something that's really exciting, and of course, if you're not in England, you may not know about this at all. And I don't want to start waffling too much, but this is an ambitious program with a scale and depth that isn't being matched anywhere else in the world. And I think that is true to say. And this is all about the Cancer Quality of Life survey. And I can't speak enough about it, of course, in 10 minutes. But this website that's been developed through NHS England, of course, is incredibly good, really. The quality of the team is fantastic, and it's a huge resource. And so that's the website if you want to get more information about where this is going. And it could just be an hour talk in of itself, of course, but I wanted to sort of bring in prompt list as a communication tool every time, linked in with the wider multidisciplinary team, e-holistic needs assessment, speech and language therapists, clinical nurse specialists, cancer support workers, and now take it up to another level in terms of national PROMS cancer data. And so I've had the honor and privilege to chair this group for a few years now. And it's been a very exciting group of experienced individuals from a whole depth of knowledge and backgrounds. And there's been a lot of pilot work, as you can imagine, several years of pilot work to try and get this right. So in September 2020, there was a 10% sample of breast, prostate and cancer. And with that, it was felt that we could go for a full launch for breast, prostate and colorectal cancer in December 2020. And I'm going to briefly talk to that. The plan then is in July of this year to bring all cancers in England on board, to start off with a 10% sample, just to make sure it's working within those cancer groups, to look at the patient summaries in a bit more detail, which I'll talk to you about. And then the plan is actually to go live in October, all cancer patients in England. And we had a lot of debate about when to do the survey. And there was an idea to try and do it at baseline, but that was going to be very difficult at diagnosis to coordinate and make it meaningful. And obviously it'd be nice to have repeated measures and that might come in and so on.
But because of the ability to really able to recognize accurately which patients have been told they've got cancer or had cancer, and to be accurate about that as much as one possibly can be, it was decided we had to compromise with an 18-month window. So basically, patients have basically been told that they had cancer, and 18 months later, they were invited to fill in a quality of life questionnaire. Some patients may have had no treatment. They may be on wait and watch prostate. Other patients might have had a really severe cancer and in fact not actually be alive to be able to contribute to the questionnaire, of course. But 18 months window, there's been a period of adaptation and they've had the holistic needs assessment involvement. And there's a bit of a watershed then at that point, and to try and see who's got problems at that stage to how it can be improved. And so from September to March, colorectal, breast and prostate, 33,592 invites, 15,708 responses. Interestingly, we're using paper and online, and the online is doing well. We wanted to get a response rate of 50%, really to get representativeness as well as to make sure that there was a meaningful number, accepting that some patients will not want to fill in questionnaires, of course. And we have champions to try to encourage that, and we're encouraging Cancer Network to try to explain the value of contributing to this in terms of future healthcare for patients. So the response rate is over the 50%, a mixture of paper and online. The lowest response rates at the moment are in the under 40s, gradually increasing to the 70 to 80 year age group. So there's ways to think about how we can encourage the younger patients to contribute. Best response rates are in prostate. There's definite geographical variations that we need to look into. And yes, there's going to be that response rate by socioeconomic strata, which again needs quite a lot of reflection to make sure that all cancer patients are given that opportunity, if they want to complete this. In terms of the measures, again, we would like at some point potentially to go to cancer-specific measures, but at the moment, in terms of the broader construct, it's the EQ5D for health utility and the EROTC Core 30. If you don't know those two questionnaires, I apologize, I can't go into detail, but they are two very, very common, well-validated questionnaires, one looking at global quality of life for all conditions that aren't specific to cancer, and the other one that is specific to all cancers, but it lacks the detail of, say, a head and neck specific questionnaire or a breast cancer questionnaire. And so it's going to be possible to summarize the specific domains in these questionnaires, and also to look at health utility score, visual analog scale, and actually the domains themselves. So in the EQ5D, mobility, self-care, usual activity, pain, discomfort, anxiety, and depression. In the future, potentially for head and neck and for all the cancers, of course, it'd be nice to get the case mix comparisons correct. It might be that we can use other data sets, so PEG tube insertion can be used to try to help anchor the outcomes. And of course, reference data will build itself, but comparison to reference data at the moment is comparison to normative population data. But there are data sets for prostate and for breast, and in head and neck, of course, there's head and neck 5,000. So it is possible to try to anchor or give some idea of outcomes for patients in relation to other patients that have experienced the same stage, treatment, and site of their cancer. In terms of the data is going to be on the Cancer Data NHS portal. And this is really, I suppose, aimed more at the network level. But in this portal for the national data, you will get information regarding incidence, mortality, survival, prevalence, diagnosis, stage, and so on, treatments, radiotherapy, diagnostic delays, outcomes. And so all of a sudden, quality of life is going to be added to that matrix and to that rubric, which is going to be absolutely fantastic. And then the other thing that's really exciting is that I was very keen, and we were very keen, to try and get it down to the individual patient level as well. So you're going to have the highest dashboard for NHS England, looking at geographical trends and high case mix analysis. You're going to have networks looking at the outcomes. And I can imagine that the psychological aspects of having head and neck cancer is going to be quite a predominant feature. I've got some preliminary data I'm not showing tonight, where it might highlight that 40% of patients are still having psychological distress and needs that hopefully could be picked up at 18 months. But again, that's a huge amount of work. There's no point doing this work without benefit and using it. But the other aspect, which I really appreciate, is this aspect, which is work in progress with the patients and the team, where basically, once the patients fill it in electronically, they're able to download a specific report on themselves. And that can go through to the cancer trackers or the primary care. And it can be used not only to allow patients to have some understanding of where they are, but also hopefully if they are identifying a specific problem, it gives them the opportunity to seek some sort of additional resources. And again, this is very exciting, individual reported outcomes, how it is going to affect the NHS and how it's going to affect individual care in the future is unknown at the moment, but it's hugely exciting. So in a sense, that's the summary. Watch this space in terms of the QOL metric. It is going to go live in the autumn, and I would really encourage us all to have a sight on that, please. Of course, to me, what's really important when we look at the opportunities for the whole team in terms of patient-reported outcomes is we need an integrated approach, and we need that integrated approach to have purpose. There's no point just doing it. It needs to have purpose. I do believe it needs to be suitable for all patients, and there's a challenge in that. Some patients may decline, of course, but we need to make it suitable for all patients if they wish to be able to be part of this. I do think that it should be from diagnosis to the end of life, and there's nuances in that, and there's huge benefit to have a patient prompt list when cure is not possible. And we're trying to develop that in head and neck cancer at the moment with a group in Copenhagen. And we need to maximize the opportunities that PROMs give us, but also recognize that we need to minimize the burden. And by having that integrated approach at various levels, the prompt list, the e-holistic needs assessment, the quality of life questionnaires built into clinical trials, the quality of life metrics, I believe that we are trying desperately to maximize the opportunities, but minimize the patient burden. As a final thing, Richard, the QOL conference that TAS is organising very kindly, it's going to be a one-day thing this year because of COVID. It got cancelled last year. That's going to be on the 12th of November. So that's something for people to make a note of if they wish to join into that. And then, thank you very much. This has been a virtual thing. It's a lovely sunny evening here, and some of you might be on different time zones. And thank you so much for taking the time to reflect on patient-reported outcomes. And with that, Richard, I'm going to open it up to further questions if there are any.
There are one or two questions, Simon. Yeah. So there's a couple of questions that have kind of tweaked, I think, the same question from a slightly different angle. It's something I've asked you before as well, and it's about remote follow-up or rationalizing discharging patients or reducing patients coming into hospital for follow-up. And of course, it's something that has happened in other specialties and been pushed, and it's something that's been slightly forced upon us during the last 15 months with the pandemic. So does PCI give you a rationale to organising remote follow-up or discharging patients from follow-up?
The answer to that is clearly yes. It really does. As long as the patient feels enabled to use it and has an access back into the clinical area, if they feel it necessary, absolutely it does. It gives that stratification, it gives that reassurance. And it's something, in a sense, I don't know what other people do, and I apologize obviously, because but in my own clinical practice, I give the patients a lot of choice about their frequency of when they want to be seen. And some patients, there was a paper that I won't mention the author particularly, where they reported in head and neck cancer a deterioration of quality of life in the long term. We haven't found that. And I think one of the reasons why they reported that was because patients were being discharged who actually needed access and were still very anxious. And so what I'm trying to say here is it depends on how you stratify it and what ability you have to reassure patients to get them back in the system. But yes, using the PCI and letting patients have more choice is really an important step forward, which will save the health service money and make the follow-up more reasonable and individualized.
Okay, and we've got another provoking question here. Assuming they're both implemented well, which would be the best to use, the holistic needs analysis or the PCI?
Yeah.
What are the advantages, disadvantages?
Well, I mean, in terms of head and neck specificness, of course, the PCI is being used routinely in clinical consultations. Every consultation is taking about 10 minutes in the consultation with the consultants, and it's there. It's something that can easily be used in clinical practice. And it's been tested within the consultant framework, and Annette Zyden's been using it in speech and language and so on and so forth. But actually, in terms of the global picture, my answer to that would be to synthesize both. And one has to then trade off the extra time it takes to do the holistic needs assessment in terms of ranking, and also perhaps a more formalized care plan. There's potentially scope to run both. Does there have to be one or the other? Not necessarily. Is there scope to somehow learn from our experiences and bring a newer tool together for national use? Absolutely.
And another question, a lot of the questions prompt concerns about dental health.
Yep.
And therefore raise a focus on oral rehab and dental rehab that we appear probably, and many countries do, we have a gap in resourcing oral rehab, whether it's dentures, implants, whether it's more complex than that. So do we create problems by inviting a demand for treatment that is underfunded and unfulfilled?
Two aspects to that. When the Canassa's paper that we looked at stage of disease, early, late, by larynx, oropharynx, oral and other, right at the top there for all of the cancer sites, whether early or late, was dental. And teeth and chewing are really important to patients, whether they have radiotherapy or not. It's social, it's humanity, and we should not forget the importance of the dental aspects in head and neck cancer. For us at Liverpool, that drove the appointment of Chris Butterworth, of course, and the agenda really is to keep raising this as an issue of priority, a little bit like fear of recurrence, to the service, to make sure that that potential need is met. There's huge scope to link with primary dental care, of course, and it doesn't necessarily have to be the specialist in the hospital, and there needs to be a clear linkage with primary dental care. In terms of creating an unmet need and a worry about that, patients don't expect a magic wand. Patients do not expect, they just want to know that where they are is something that they've got to live with. I know I'm sounding perhaps a little bit trite here, and I apologize for that, but actually just to be able for them to talk about their problems and recognize where they are in that cancer treatment actually is often treatment of itself. And if you're really wanting to address the demands of a patient regarding dental health, it needs to be at baseline as well. It needs to be at diagnosis, because some patients are very, very concerned about their teeth and chewing, more so than their cancer sometimes. So even though it's what I'm trying to say is, even though a prompt list may identify a difficult issue in terms of healthcare resources, it doesn't mean it shouldn't be talked about, and it doesn't mean that it's not going to be helpful to talk about it.
Thanks, Simon. We have reached 8 o'clock, 1 minute past 8. So I'm going to thank you on behalf of the Head and Neck Centre. It's fascinating looking at the content of your last bit of your talk. The Head and Neck Centre's had talks on everything from clinical trials, molecular biology, from quality of life, patient concerns, global side with COVID, all sorts of the different topics. I find it fascinating. And I wouldn't have predicted it was possible, but it looks like now in the NHS, for our NHS patients, not only are we going to offer comprehensive sequencing, mutation analysis for all tumours within a few years, it's already happening to large numbers, but also quality of, and we've got this richness of data of quality of life that's going to come in for, you know, hundreds of thousands of patients. And we're going to have this information in the NHS that I suspect won't be had in other health systems. This sort of well-organized system is fascinating. And Simon, I think the quality you bring to this and your experience and your commitment to this field is reflected by the fact we've had 100 participants, which is as many as we've had, I think, before. And we're on, and as you say, a lovely sunny summer evening. So congratulations to that. And that's a great, it's a great event for the Head and Neck Centre to be able to host you. Thank you very much.